Hello friends, hi. My name is Vinayak Rengan. I'm a general laparoscopic surgeon. I did my MRCS from the Royal College of Surgeons of Edinburgh. Today we're going to be discussing an extremely important topic: professionalism, consent, ethics and child abuse. This comes under medical legal aspects of surgery, and for sure you can expect at least 4 to 6 questions from medical legal aspects of surgery in your MRCS Part A. We are very committed to making sure that you understand this topic in depth and in detail. Let's start with the concept of consent. Consent means a person, he or she, or even child, should give permission before they receive any sort of medical treatment, test, or examination. In certain cases, it can be a verbal consent, provided it obeys all the rules of consent, which you're going to be discussing later, or it can be a written consent. And this consent must be done on the basis of an explanation regarding the test, the procedure, by the clinician who is going to be treating the patient. Consent is needed irrespective of the procedure, whether it's a physical examination, organ donation, or any procedure. The principle of consent is very important from the concept of international human rights law and medical ethics. So it's not just enough to give a consent. The consent should be valid. For the consent to be valid, there are 3 major criteria it must fulfill. First, the consent must be voluntary. Second, it must be an informed consent. Third, the most important one, the patient must have capacity, the mental capacity to understand, to weigh the decisions, weigh the pros and cons, weigh the risk and risk-benefit ratio before arriving at a decision. If an adult has the capacity to make a voluntary, informed decision and that decision has been made in the full mental capacity, their decision must be respected. This can sometimes reach have extreme consequences. A person might refuse a treatment, a transplant, a major surgery because of certain religious beliefs or certain social norms. But if the patient has made an informed decision, then you should be respecting that decision. If the patient does not have the capacity, do check whether the patient has made or nominated an LPA. LPA means a lasting power of attorney, which is a legal document made by a person above 18 who is anticipating that he or she is going to lose his or her mental capacity in the future and nominates a friend, a relative, one or even two or even more than one to make decisions on their behalf. We will be discussing about LPA in detail further. You should discuss the situation with friends and family before making any sort of decision. Their opinions, the patient's opinion, are always to be considered. If a patient does not have an LPA, does not has made a lasting power of attorney, and he or she does not have the capacity to make a decision, the right to take a decision depends on the consultant. So the consultant who is treating the patient, the team, surgical team which is treating the patient, will be making the decision on behalf of the patient in the patient's best interest. Note the point, in best interest. You cannot take a decision which is disregarding the patient's best interest. An 80-year-old lady with multiple metastasis has a small hernia, she comes in with a surgery. You can take the decision not to operate on her because her life is, has hardly a few weeks. So that decision will be made by the consultant if the patient does not have the capacity to consent. There is no role of a relative, there is no role of a friend, there is no role of next of kin unless they are nominated as an LPA. This is a very interesting concept, a concept which a lot of South Asian, Middle Eastern students fail to grasp because in many of these cultures, the decision in the terminal stages is made by the family. In UK, the entire treatment is taxpayer subsidized. That is how the NHS works. And in NHS, the decision is solely made by the patient. If the patient does not have the power, it is made by the consultant. Do remember this point, extremely important. Most of your questions will be regarding this point. Before we deep dive, I want to talk about different types of consent forms. Consent form 1 is a patient agreeing to a treatment or an investigation. Consent form 2 is for children. Parental permission for an investigation or treatment. Consent form 3 is parental or patient permission or agreement for a procedure where consciousness is not impaired. Consent form 4 is the most important form for us. This is the legal basis on which the consultant takes a decision for a patient who lacks capacity to take a decision. This, of course, is if the patient has not nominated an LPA. Very important, do remember this. So, coming to parental permission, consent form 2, let's look at a question. Rita Warrior is a smart, very brilliant 14-year-old girl who comes to GP and says she's pregnant. She's had a urine pregnancy test and she does not want the child. She does not want her parents to know about the procedure. Now, do explain what is Gillick competence. Would you do the abortion or would you not? A child cannot consent to their own medical treatment. From an Asian culture, from a Middle Eastern culture, this appears to be a very logical explanation. B, a child of any age can consent to treatment if he or she fully understands the medical treatment proposed. Looks like it. I don't know. Let's see how it goes. A child of any age can consent to treatment if he or she fully understands the medical treatment, but this must be supported by at least one parent or guardian. I think this is something which Asian parents would agree with. A child can consent but it has to be supported by two doctors and is in the child's best interest. Now, this also appears to be very logical. Parental rights outweigh the rights of the minor? Never. We are living in a civilized world. The child also has rights. Do remember that. So, the answer is a child of any age can consent to treatment if he or she fully understands the medical treatment proposed. Now, this is called as Gillick competence. Gillick competence is a very, very important part of your MRCS Part A examinations. In the UK, the age for medical consent, a minor is legally considered an adult for medical legal purposes if he or she crosses the age of 16. So before 16, the parent has the rights to take decisions on the behalf of the child, provided the child cannot make decisions on their own. When I use the term Gillick competent, it means that the child, whatever be the age, has the capacity to understand the consequences of the decision, has the capability to recapitulate what you have told, has the capability to weigh the pros and cons of whatever decision he or she is going to take, and to understand the consequences or the implications of the treatment he or she is going to undergo. So this is called as Gillick competence. So this is Victoria Gillick. She's a Catholic mother, a mother of 10 children. She vehemently opposed right to contraception by children because she thought that would encourage promiscuity. So she achieved fame by having an eponymous law named after her. So this was in 1985 because the House of Lords passed the ruling which said that, a GP can prescribe contraception to a child, a minor, if he or she wishes it, and they need not inform the parents. So this 14-year-old girl, revisiting the question, has the right to get an abortion and her parents need not know about it. A 17-year-old boy, Matthew Bennell, was riding his uncle's bike and got into a motor vehicle accident. The fast scan shows ruptured spleen and he's unconscious. His BP is dropping rapidly. Emergency splenectomy is proposed. What would you do? Contact the parent to seek consent? Look, the age of consent medico-legally is 16. Option A is ruled out. That's a decoy. Contact social services. It's 3 a.m. Nobody in social services is likely to respond. And you also don't have time. The child's BP is dropping. Treatment cannot be initiated as the patient is unable to consent. Absolutely illogical. You will have to make sure that the patient is operated as soon as possible. Consent by proxy, that leaves us with two options. Consent by proxy or proceeding without consent. When we put up this question in test and discussion for our Mortimer Green users, most of them opted for option E, proceed without consent, because I just explained to them what consent form 4 is. But consent form 4 is a type of consent by proxy. The surgeon, the consultant, makes the decision for the patient on his behalf because he lacks the capability to take a decision because he is unconscious. So you do what is in the best interest of the child or the boy and go operate on him and remove his spleen. So you are a surgical trainee, Habib, and you are going to remove a lipoma under LA. Pretty interesting stuff. And your consultant is going to be scrubbed in as an unsupervisor. He's not going to be scrubbing in, sorry. He's going to be sitting there as an unscrubbed supervisor. You go to consent the procedure. Which of the following? You do not have to mention the non-operative management. Yes, you absolutely need to. That is a major part of the consent. You do not have to mention the risk of reaction to local anesthetic as it's so rare. Never. Local anesthesia reactions can be very severe, can be fatal. They need treatment, and you will have to mention it. It's not just going to manifest as a small allergy. It's going to manifest as a major anaphylactic reaction, which might need complex medications such as intralipid. You need not mark the site as it is local anesthetic. No, all procedures, everything has to be marked. You should put a single identifier like the patient's name on the consent form. This is Jacob Roswell. There could be another Jacob Roswell. Just name is not enough. And it just demands that you put 3 patient identifiers. What are they? First one, name. Second, date of birth. And the third one is the NHS or the trust ID. E. You should state you will be doing the operation with supervision. This is the only correct option. You should inform the patient who will be doing the procedure. You should inform the patient about your experience or the lack of it. You should inform that the consultant is going to be there supervising you. As we told before, all non-operative management needs to be mentioned. LA reactions need to be mentioned. Site needs to be marked, and 3 patient identifiers are necessary. And it's up to you to convince the patient whether he's going to agree for you to operate on him. And in a very Asian or in an international scenario in the third world, this would not be a problem at all. But to remember, switch out of your comfort zone, switch out of your mental, break your mental barriers, and think that you are a trainee or an SHO or a registrar in the NHS, and behave according to that. Do solve questions on our MCQ bank to see more such scenarios. We'll be discussing a lot more over the course of the session. Hey guys, hope you're doing well. I hope you enjoyed this video. This particular video is a snippet from our MRCS Part A video lectures. What you saw just now was a small part of our larger video series on medical legal aspects of surgery, where we cover concepts on UK health, NHS regulations, child abuse, ethics, consent, workplace scenarios, and much more. All these are important concepts for your MRCS Part A examinations, and some of these concepts will be carried over to even MRCS Part B. Dr. Rohan Khandelwal and I have designed this comprehensive set of video lectures purely to help you clear MRCS Part A exams with ease. And we hope that you utilize this resource. Keep watching the space for more updates, and we hope to launch this video lectures by the end of July or early August. Thank you so much.